Hi, I'm Bill Prentice. I'm the CEO of the Ambulatory Surgery Center Association, or ASCA. We're the only national trade association that represents all surgery centers of any type. And I'm here to give a quick overview of things that we're working on. And as a synopsis of what I'll be covering, I think I'll start off talking about a couple of major regulatory issues that we're focused on, turn to Congress and some legislative activities we're focused on, some other issues that are in play nationally that would be of value or of interest to folks in the ASC community. And I think I'll close by talking a little bit more about the association and some of the major activities that we're working on that benefit surgery centers and for which you all could be involved in. So I'll start with the regulatory front, and obviously the big issue in front of us right now is our Medicare payment rule. The proposed rule came out this summer in mid-July. We had a couple of months to review the over 900 pages in the rule and submit our comments to talk about the things we liked and the things we didn't. And then the Centers for Medicare and Medicaid Services, or CMS, will issue a final rule. Statutorily, it's supposed to come out on November 1st, but in a few minutes, I will talk about a possible hiccup to that. When we look at the rule, the proposed rule, some of the major features, of course, every year are the inflationary increase that they're proposing to surgery center reimbursements for the coming year. Any changes in procedures that you would be allowed to perform on appropriate patients in the Medicare setting of Medicare beneficiaries in 2026, and then some changes to our Medicare quality reporting program. So starting on the payment side, this year they've proposed a 2.4% on average increase to Medicare reimbursements for ASC procedures for 2026. That's the same inflationary update that's being proposed for hospital outpatient departments. And the reason for that is that for the last 7 years now, we've been on the same inflationary update as the hospitals, using an inflation factor known as the hospital market basket. And that differs from prior to that, when ASCs were being reimbursed under the Consumer Price Index for all urban consumers inflationary index, while the hospitals were still on that hospital market basket. And one of the implications of that was that every year, when we were on separate inflation factors, because medical inflation generally outpaces overall inflation, we were falling further and further behind the hospital outpatient departments in terms of our reimbursements. We're already reimbursed almost 50% less than the hospitals for doing the same procedures on similar patients. But those two different inflation factors were making that situation even worse and making the delta between what we were being reimbursed at surgery centers versus hospital outpatient departments getting wider and wider. So we're very pleased that under the last Trump administration, we were able to convince them to do a 5-year pilot of keeping surgery centers on the same hospital market basket inflation factor as the hospitals. Due to the COVID-19 pandemic, we were able to convince the Biden administration to continue that pilot beyond the 5 years. And we now have, in this proposed rule, an understanding that this administration can at least carry forward that hospital market basket for surgery centers at least one additional year. Obviously, one of our comments is to try and make that change permanent, because I think being tied to the hospital market basket is obviously of good benefit to surgery centers in terms of our reimbursements, and keeping us at least on par and not falling further behind the hospital market, the hospital outpatient departments in terms of our reimbursements. So we're hoping that we get that 2.4% increase in the final rule. That number could change a little bit up or down based upon changes that they might see in that inflation factor from the time that the rule came out in July until it's finalized later this year. But I think we can expect something around that number. The second big thing that happens in our Medicare payment rule is they make changes in terms of the procedures that ASCs are able to get reimbursed for when performing them on Medicare beneficiaries. One of our longstanding concerns about the Medicare program is that it has been very conservative in terms of the procedures that allows ASCs to perform relative to the procedures that you perform on commercial patients. So we every year we are approaching the agency and talking to their medical directors and suggesting procedures that we know that surgery centers are safely performing on non-Medicare patients and for which we believe we could be reimbursed and perform safely on appropriate Medicare patients. This year in particular, we were looking to add procedures in the spine category and cardiovascular. So we proposed a number of procedures that we wanted to see added to that list. We're very pleased that most, but not all of those procedures were added to the proposed rule, meaning there's a good chance that they'll be added to the ASC reimbursable list in 2026. We were a bit disappointed that some of the cardiac procedures that we and the cardiology community, which includes the American College of Cardiology and the Heart Rhythm Society, were not in the proposed rule. And so in our comments and in the comments from those cardiology groups, we have asked for reconsideration of that, believing that we could safely be performing those procedures on appropriate patients. Some might recall from the last year of the last Trump administration, they made a rather sweeping change in terms of the procedure list, in that they had proposed to do away completely with the inpatient only list. That's the list that indicates procedures that could only be performed in an inpatient hospital. And you may recall that in the last year of the Trump administration, they actually proposed to do away over a 3-year period with that inpatient only list. And in that final year of the Trump administration, they actually proposed to do away with most of the musculoskeletal inpatient only procedures, opening them out to be performed either by hospital outpatient departments or surgery centers based upon the clinical judgment of the physician. First year of the Biden administration, they actually pulled all that back and retracted all of those changes. So in this proposed rule, it's not a surprise to us that actually the administration is proposing once again to do away with that inpatient only list, meaning that there's over 270 formerly inpatient procedures that, if finalized, would now be able to be performed in a hospital outpatient department or a surgery center on appropriate patients. Now, an important consideration about that is that doesn't mean that those procedures cannot still be performed in an inpatient hospital. Indeed, we believe that the great majority of those procedures and great majority of cases on those procedures will likely still be performed in the hospital, in the inpatient hospital, and only slowly move to the hospital outpatient department and the surgery center as surgery center physicians become more comfortable performing those procedures, and as we're sure of, picking the right patients to do those procedures on an outpatient basis. But I think the overall theme of this is that this administration is going to rely on the clinical judgment of the physician being the best determinant of where a patient can get her care, rather than a medical director in CMS, adhering to a rather conservative belief about where procedures can be performed. So we're very pleased about that. Again, I think there's still some work to be done in terms of the procedures that we know we could be performing on the cardiac front, and we're hopeful that we'll see some of those added in the final rule. Third leg of what we're always focused on with our Medicare rule is quality reporting. As some of you may know, we were instrumental in convincing the agency, about 15 years ago, to create a Medicare quality reporting program for surgery centers. And while we know this is a regulatory burden on surgery centers to have to, comply with this quality reporting program, and it's gone sideways some ways in terms of some of the things that you've been asked to report on, overall, I think there's been, tremendous success in terms of the results that we and policymakers in Washington and the health media see in terms of the great results that we, report to CMS on these measures. That's really done a lot to increase the faith and confidence of folks in the type of care that you're providing in your setting. We've always known that surgery centers were very safe, patient-friendly places to get health care, but now we can actually point to our quality reporting results to prove it, and that's been very helpful to us. That said, as I mentioned, I think that our program's gone a bit sideways in recent years in terms of some of the measures that you've been asked to report on. A perfect example being the COVID-19 measure that was implemented in the prior administration, which required monthly reporting, and for which we saw no value. I'm very pleased to report that that measure is proposed to be pulled back. So we won't be able to say that officially until the final rule comes out, but we're very pleased to see that finally they're going to do away with that COVID-19 reporting measure that I know is a huge struggle for surgery centers to report on. In addition, last year there were 3 measures proposed dealing with health equity and social drivers of health. Those 3 measures are also proposed to be eliminated, something that we had been asking for as well. Not because we don't believe in the importance of equity in terms of healthcare, but these measures really weren't set up to be applied in the surgery center. They were going to be a burden on you and your staff to implement, and they really were of no great value and had not been tested in the surgery center setting. And that last point is one that's really important to us now, is that we have the ASC Quality Collaboration working and developing proposed measures of quality in the ASC space that are specific to surgery centers and that have been tested in the surgery center setting for appropriateness. And one of our big frustrations with CMS and our quality reporting program in recent years is that they've been trying to apply measures like these social drivers and health equity measures that had never been tested in the surgery center setting. And so we have now taken the position that if a measure has not been tested in our setting for appropriateness, no matter how otherwise meritorious it might seem, we're going to oppose it. So that's going to be our position going forward. So in summation, we're really pleased to see that in this proposed rule, they're talking about clawing back some of these measures that we think have never been tested in our setting, which was just going to add a burden to you to report, and for which we saw no value. Now, there is unfortunately one new proposed measure that kind of meets those same problems that I just discussed, that has been proposed for addition to the ASC Quality Reporting Program, albeit not for a few years, and that is a measure that deals with post-discharge instructions. In our mind, in looking at this measure, it is a solution in search of a problem. We know of no evidence, no research that has indicated that the discharge instructions that ASCs are using with their patients are not being complied with, are not good, and that we have a problem with patients not understanding them. So we are opposing this proposed measure on those grounds. It's never been tested in the surgery center setting, and they can point to no documented evidence that there is a problem with the post-discharge instructions in our setting that needs to be addressed by having this survey of our patients. So that's the top line concerns and interest with our proposed Medicare rule. As I mentioned, that statutorily it's supposed to be finalized on November 1. However, as I am recording this presentation, we are 8 days into the government shutdown. The longer that this shutdown goes on, the less likely it will be that CMS is going to be able to hold to these deadlines in terms of issuing these rules. So there is a chance, if this shutdown goes on significantly longer, that they may not meet that November 1 deadline. The significance of that is that you're going to have less time, obviously, to implement all of these changes and be ready to go on January 1 when the new rule will take effect. You can rest assured that ASCA will be monitoring this, and that as soon as that rule comes out, we'll be sending out to ASCA members, all the details of what's in the final rule, any changes from the proposed rule to the final rule, to give you the best chance of obviously getting up and running and being ready to go with the new rule in January 1st, 2026. A second regulatory issue that we're closely monitoring is a demonstration project on prior authorization in surgery centers in 10 states on a limited number of procedures. The odd thing about this proposal is that it came out of the Biden administration last year, came out of the blue, really wasn't being subjected to the normal rulemaking process, and was going to require in the 10 states with the largest penetration of ASCs, which would include New York, that you'd have to get prior authorization for performing a number of procedures on Medicare beneficiaries. The very odd thing about this is that the codes that were selected for this demonstration project um, made no sense. And quite honestly, the great majority of the codes, surgery centers are not performing or performing at extremely low volume. And some of them were part of APCs and couldn't be built separately. So it was very confusing to us, one, why this prior authorization project was being implemented at all when there is no evidence of fraud or abuse on any of these procedures in the surgery center setting, why they picked the states, and why they picked these specific procedures. So we obviously pushed back on that proposal when it came out. With obviously the change in administration, I think we all felt confident that that one would not rear its ugly head again. So we were quite surprised to see that it actually has come back, and that this administration is proposing the adoption of this prior authorization demo project starting in mid-December. We are obviously pushing back on that. ASCA is just sending a letter this week to the agency pointing out that, amongst other things, the government shutdown is going to make it very hard for us to deal with this, and that it has the same flaws as the proposal from last year, and that we do not do most of the procedures that are included in this prior auth. Obviously, that means the actual impact of it would be pretty negligible for the most part, but there is one or two procedures that are done with some volume in surgery centers that would impact you. But again, without any evidence that there's any fraud or abuse, we don't see the point of this prior authorization project at all. So again, stay tuned as we find out from the administration whether they're going to continue to pursue this, or whether they'll listen to our concerns and pull that back before the end of the year. I think I'll stop there in terms of the regulatory issues that we're focused on, and turn my attention now to the legislative side of the equation and Congress. No surprise to any of you that we are obviously in a bitterly divided time in this country with a bitterly divided Congress, and this government shutdown that we're currently in the middle of is obviously a very strong indicator of that. I'm not going to get into the details of the shutdown, other than the fact that the Republicans are trying to pass a continuing resolution, which is a legislative maneuver to continue funding the government at current funding levels. And the Democrats are pushing back because they believe the Republicans are not focused on a key healthcare issue, which is the fact that at the end of the year, the premium tax credits for the Affordable Care Act are going to expire, meaning that the cost of buying health insurance is going to go dramatically up for millions of Americans starting in 2026. Republicans are claiming that they're willing to look at this issue, but don't want to have to be tied to this continuing resolution. Democrats believe that the only way they can ensure that this issue will be addressed is having it being done as part of the continuing resolution. All that being said, it's an issue that could have tremendous import for healthcare next year in terms of healthcare premiums going up, fewer Americans having health coverage, and that could obviously have a very quick downstream impact on surgery centers. So it's one we're watching carefully. In terms of specific ASC legislative issues, there are two bills that we're looking to have introduced in Congress that focus on you. The first has already been introduced. It's a bipartisan bill that's been introduced in both the House and Senate to deal with a rather perverse element of the Medicare program, which deals with coinsurance or the copay cap. And this is an element of hospital law regulations where a Medicare beneficiary who receives his or her care in a hospital, whether inpatient or outpatient, has a cap on their coinsurance that this year is roughly around $1,600. So meaning no matter how expensive the procedure that they're receiving from the Medicare program costs, they're not going to pay out of pocket more than that $1,600 or so. The problem is that there is no coinsurance or copay cap for ASC procedures, meaning that we're in this, as I said, perverse area where it costs more for a Medicare beneficiary to receive care in some instances in the surgery center, even though the cost of that procedure is 50% or more less than getting it in the hospital. So we have this perverse disincentive for some Medicare beneficiaries to get care in a lower cost setting that saves the Medicare program money and saves we as taxpayers money because it's going to cost her more to get her care in the surgery center than the hospital. This is an issue which obviously when we explain it to lawmakers, their eyes pop wide open, makes no sense to them. As I said, we have bipartisan interest in this, and we're really looking to grow support and get this copay or coinsurance cap addressed, this year. One of the ways we do that, of course, is by asking you to meet with your lawmakers and help us to tell the story about how these things impact you. So we had our National Advocacy Day in Washington a couple of weeks back, where we had over 100 ASC professionals from around the country meeting with their lawmakers and staff, talking about this issue. We need you to do that. You all have to be advocates for the ASC model, advocates for these changes that we're looking to make. A great way of doing that is to host a facility tour for your lawmakers. So whether it's your member of Congress, one or both of your U.S. senators, your state lawmakers, we need you to bring them into your surgery center and let them know the type of things that you're working on and the pain points you're facing that the government could be addressing on your behalf. I always talk about the fact about how outspent and outmanned we are by the hospital community and the hospital lobbying presence in Washington. The best way for us to address that is to have you also be part of that team in terms of educating your lawmakers about the things that matter to us. The really good news is the issues that we're fighting for you are ones that are common sense, that by and large don't cost the government much more money, but which can really improve, the migration of cases to the surgery center space, help Medicare beneficiaries get more care in the safe, cost-effective, and patient-friendly environment that you provide. And in the meantime, save the government billions and billions of dollars. So I hope you'll take advantage of this request, that you'll go to the ASCA website and find out how to be more involved in our advocacy and how to host a facility tour. It's a great way of getting to know your lawmakers, and it's a great way of making them advocates for ASCs. So I hope you'll do that. The second ASC bill that hasn't been introduced yet is our broader bill that includes multiple provisions to try and fix different pain points we have with the Medicare program. That bill would have been introduced by now, but for the fact that the House and Senate have been out of session a lot this fall. And now, of course, we're faced with this government shutdown, so there's no legislative activity at all. But we're hoping as soon as they come back to Washington that we'll get that bill introduced. Once again, we'll have bipartisan interest in it. We'll have co-sponsors in both the House and Senate, and we'll get that word out to you as soon as we have it. A few other issues that are out there that I know that are of great great concern to surgery centers are things like site neutrality, anesthesia, and obviously concerns about possible legislative or regulatory activity around private equity. So I'll just address each of those for a minute or two. Site neutrality is something, it's kind of a interesting policy development that's receiving a lot of time and attention in Washington now, which deals with the idea that we know that patients can get the same procedure performed in an inpatient hospital, in a hospital outpatient department, and a surgery center, but that when they do so, the government pays them significantly different amounts. That we know that obviously the inpatient reimbursement for a knee arthroscopy is higher than it would be for a hospital outpatient procedure, and even much more higher than obviously what you get reimbursed for doing that TKA in a surgery center. And so the question that's being asked by policymakers is, why do we pay three different amounts for the same procedure? And so there have been, legislative proposals drafted but not introduced to basically do away with that and say that we should only be paying one price for that procedure, regardless of where it's performed. And there's different ways of deciding what that price would be, but in most cases, it goes to where the highest volume of that procedure is being performed. Um, the idea here, though, is not to pay you more. And that's the really important concern we have about site neutrality, is that it's really trying to depress rates down to the lowest possible price for a given procedure. And the problem with that is we know that all patients are not the same. Patients have different comorbidities, different risk factors associated to them. And so when a patient is seen in a higher regulated environment, so in our case, say a surgery center versus a physician's office, there are very good reasons for that. And so we're very concerned that in a site neutral policy, we would have many of our procedures where we would lose our ASC reimbursement and be reimbursed at the physician office level. Likewise, the same thing would happen in procedures where formerly hospital outpatient procedures would be reimbursed at the ASC rate. Again, that might seem like a good thing in terms of that would result in more volume going to the surgery center. The problem is that we know that there are patients, because of their comorbidities, because of risk factors, belong on a hospital campus, belong in a setting where they have closer access to critical access care. And obviously, a hospital should reimburse higher for taking on that additional risk. So overall, our concern with site neutral as a policy is it's focused only on price, about lowering the cost of healthcare, and it's not focused on ensuring that patients get the best care they can in the setting that makes the most sense for that individual patient. So that's our position on site neutrality. Fortunately, there's been no real significant legislative activity around this issue yet this Congress, but it's one that still receives a lot of talk, but one which we're being obviously very much concerned about and staying on point about. Anesthesia is another big concern that we hear every day from our members in terms of access and the cost of getting anesthesia providers into your surgery center. I want to let you know that ASCA is obviously very concerned about this issue. We actually participated in a summit meeting this summer with the American Society of Anesthesiology and the Society of Ambulatory Anesthesia to talk about these concerns and see if we can find a path forward where we could be all working together to try and address these really unsustainable, cost increases for anesthesia that many surgery centers and hospitals are facing right now. No quick solutions to this problem. As I say, this is a problem that's probably 40 years in the making, from the closing of anesthesia programs and residency programs back in the 80s and 90s. I don't think we have enough anesthesia providers. I think there's also downward pressure on anesthesia reimbursements that is playing a role in this. We know that in terms of what anesthesia is paid by Medicare by unit, is a ridiculously low amount. They're making it harder and harder for anesthesiologists to afford to do what they do without seeking some additional compensation somewhere else. And unfortunately, what that has turned to is a lot of anesthesia groups asking for bonuses and supplementary payments from hospitals and surgery centers in return for providing anesthesia in that setting. I think we all know this is a problem that's not sustainable. I think that we need to work with the anesthesia community to try and get them better reimbursements, both from the Medicare program as well as from commercial payers, so that we don't have to pay these ridiculous bonuses in order to get the anesthesia that is so critical in order to provide the care that we do to our patients in the surgery center setting. Last issue I mentioned is there's a lot of attention around the country with private equity and its potential negative influence on healthcare. That we've seen legislation introduced in various states to deal with this issue, to require various reporting requirements. If you're getting working with private equity to get access to capital. Our overarching position on this is that if there's going to be any regulation of how private equity is used in healthcare and how we make sure that it doesn't have a negative impact on the care or the quality of the care that's being provided, that regulatory requirements should be on the private equity firms, not on the healthcare provider. You are regulated more than enough, and we certainly don't think that you should be forced to have to report on the efforts you make to try and ensure that you have the capital you need to run a really great surgery center, to buy the equipment you need, to expand. If there's going to be regulatory requirements about how the influence of that capital, let's put it on the private equity firms, not on the surgery center. So I think I'll close now with just talking a little bit more about the things that ASCA is working on your behalf. Obviously, I spent a lot of time talking about advocacy, and we have a great government affairs team that is obviously focused on all the legislative and regulatory issues at the national level that either impact you or could have an impact on you. Likewise, we work on state government affairs. We have an effort. We track all the legislation and regulations that are popping up around the country, making sure that we're helping our state associations and our members in states that don't have an association be aware of the things that are popping up in their state capital that could have a positive or negative impact on them, and then trying to work with those state associations to try and manage those issues. We work very closely with the New York Association, which has been doing a great job on your behalf. My one request of everyone here that's an ASC member or an ASC is be a member of the New York Association, be a member of ASCA, be involved, because it's only through your support that we're going to have the resources to be able to manage these challenges and handle all these legislative and regulatory issues that have such a big impact on your bottom line and your ability to provide really good care. So beyond advocacy, we also are very focused on communications, making sure that we're monitoring the media from a national perspective to make sure that ASCs are being portrayed correctly and appropriately. Too little of the health media understands what a surgery center is and the great care that you're providing. So we want to make sure that if an ASC is being featured in the news or something's developing, that we have an ability to respond and make sure that these reporters understand who you are, what you do, and the great care that you're providing to your patients every single day. We also have an enormously popular education program. We provide dozens of webinars and virtual seminars each year on topics of interest to surgery center professionals to make sure that everyone in your facility is up to date on what they need to know from an education and training standpoint to provide great care to your patients. One of the big changes that ASCA made last year that has been enormously successful is we actually have done away with the pricing of our virtual education for members, meaning that anyone who's a member of ASCA can access all of our virtual education, albeit webinars or virtual seminars on a host of different topics, and do it for free. So there's unlimited access, but for you and everyone in your surgery center, if you're a member of ASCA, to access that virtual education to make sure that you are up to date on the things you need to know to run a safe and effective and cost-efficient surgery center. So I'm very pleased about the development. As I said, it's been enormously successful. We've actually more than doubled participation in terms of users of our virtual education once we did away with that price barrier. So if there's no other reason, being a member of ASCA will pay for itself by just having access to all this education for free. Another really important program that we have is our ASCA benchmarking. We have the largest and most substantive clinical and operational benchmarking program in the ASC community, where you can benchmark yourself against others of like specialty from the same market, from the same state, on a host of clinical, operational, and financial measures. One of the things we know, though, is over time, our benchmarking platform has gotten a bit stale. It's gotten old. It's not as user-friendly as it could be. So we've done a dramatic, overhaul of our benchmarking this year. We've identified a new platform for our benchmarking that's going to be much more user-friendly and customer-friendly in terms of being able to input data and then to pull out that data and run reports that you can share with your governing body, with your team to use to improve. And really importantly, we have also had our quality and benchmarking committee actually review all the questions, the data points that have been in our clinical and operational benchmarking for a number of years to make sure they're still pertinent and they're still the measures that make the most sense for an ASC professional that you can use to take action to make sure that you're running the best center possible. The last and probably biggest thing change we're making with our benchmarking is heretofore we have charged a nominal amount of money each year to participate in our benchmarking. Like our virtual education, we're doing away with that in 2026. So this new, better benchmarking is going to be free to members. And our hopes are by doing that, we're going to get even more participants so that that data will even be richer and more actionable because we're going to have more people submitting data each quarter to it. So look forward to that in 2026. It's going to be, I think, a tremendous benchmarking tool that you're going to want to use that I think your governing bodies will also be very pleased with when they see the results of it. Final thing I'll mention is just the many, many ways that we communicate with you. And again, if you're an Ask a member, you have ready access to these. So we have obviously ASC Focus, which is the only magazine that is focused only on ASCs and what's happening inside surgery centers. Every single issue of ASC Focus is just chock full of useful information about how you can run a better surgery center, how you can improve yourself and your position. It's just a tremendous tool that gets mailed out to every Ask a member every month. So please, make sure you're looking at ASC Focus. It is just an enormously successful, resource, has just tremendous information for you each month. Likewise, we have Ask a Connect, which is our online community for Ask a members, where you can ask each other questions and get information that you need from your colleagues around the country about any problem or concern or question you have about working in your surgery center. It has been an amazing tool. It basically allows you to just crowdsource answers to problems you're facing. It's enormously successful, and any Ask a member can access that whenever they like. You obviously get a daily digest of the questions that have been asked, so you can find things out that you maybe didn't even know you had a problem with by just looking at Ask a Connect each day. Finally, we have our news digest, which comes out once a week, which is a collated collection of news around surgery centers and health issues that might have missed your attention, that we kind of put together for you in a little quick digest so you can stay up to speed on the issues around surgery centers and healthcare that would be of interest to you. Likewise, we have a government affairs update that comes out every week that once again highlights the federal, legislative, and regulatory issues of interest to you, some of the top line state issues that might be popping up around the country, which may be of interest and concern to you. Just again, another opportunity in 2 or 3 minutes to find out what's happening in the ASC world that would be of value to you. So my final plea to you is that I hope that you will become a member of ASCA. If you're not, that you'll become a member of the New York State Association, and that you can work with us to try and solve the many issues and complexities that are facing surgery centers. We also have a number of great volunteer opportunities to serve on the ASCA board or an ASCA committee to help manage what we're doing and make sure we're focused on the issues that are of interest and concern to you. So with that, I think I'll stop there. I hope you're having a great day at this Garfunkel Wild Conference. And if you have any questions about anything that I've covered, please feel free to reach out to me or anyone on the ASCA team so that we can be responsive to you. And I hope you have a great day. Thank you.